to speak on this topic. Now, as a maxillofacial surgeon or as a dentist, because there are many dentists who will be practicing, we first see oral cavity. We are more interested in oral cavity. So day in and out we see it, and the main function of the oral cavity is to enjoy the food, that is the function, and aesthetics, look good, smile, enjoy life, that is the function. And we all should and everyone should take care of it. But if it is not respected, or rather when it is disrespected, misused, then we see such pictures. So we can say it is preventable to a large extent. So if not respected, we can see such huge large masses, and when treated, there are two ablative procedures. And deformity will be there. Bringing the patient to the normalcy is very difficult or impossible, we can say. The incidence, if we see, it is very much in our country. Why? Why in our country? Because the etiologies are more used or more consumed things are in our country, like tobacco, areca nut, betel nut, maybe with alcohol also added, and this is also a factor, malnutrition, and these habits then again it add. This is preventable to a large extent. When we see cases with a sharp teeth, we should make an effort to make it smooth. Constant irritation for months lead to malignancy. Viruses, yes, they have a role and can lead to malignancy. Now, how it present, the signs and symptoms. Sometimes it is so obvious, just have a look and we may say it is positive. Sometimes it is so obvious. Why such an extensive lesion? Usually patient come because they are painless. There is no alarming things. Patient को लगता है सब बढ़िया है, कुछ नहीं हुआ है मुझे. Routine is very normal. He comes only when secondary infection is added and there is a pain. So he comes for the treatment of pain only. Sometimes the symptoms are not that obvious. We need to be meticulous in observing and evaluating the case. We can see an ulcer or an induration, or patient may complain difficulty in speaking, swallowing, movement of the tongue if the floor is involved, change in the voice, or trismus when the masticatory muscles are involved. And this is common with the dentist, non-heel extraction socket. And we should be more careful when you are extracting the teeth. If the tooth is mobile without any obvious reason, have a suspicion that malignancy is already there. And if you are removing the tooth from the malignant lesion, then patient will blame you because of your extraction I had a malignancy. So be careful when you are dealing with the mobile teeth. Now, sites of presentation, any site in the oral cavity can be involved. These are the sites, and we may present it on one's units only, like tongue, oral tongue, or it may additionally involve the floor of mouth, may start in the mandible, then vestibule, buccal mucosa. So we know the units, but it keeps on spreading if the patient doesn't report, and may involve the lip also and retromolar trigon also. Now, when you evaluate the case, we first inspect and palpate entire oral cavity and additionally neck. Oral cavity में everything we know, तो buccal mucosa both side, tongue both side, inspect and palpate also for any induration or ulcer, and floor of mouth also. So in palpation, this finger have a diagnostic value. When you feel the normal, it feels soft. And when you, even obvious symptoms may not be there, but induration may be there on buccal mucosa or tongue. So move your tongue in all the parts, in the floor of the mouth. And neck node palpation also has to be done. Why? We are dealing with oral cancer. Why? To see the neck nodes. Patient को flex कराते हैं and we feel the neck nodes. Why?
Malignancy.
Yes. In malignancy there is a lymphatic spreads, and that spreads to neck nodes in the region which it is draining. Like here we can see, ये region submental है, तो इसमें इस रीजन के ड्रेनेज है, लोअर लिप, लोअर ऑफ माउथ. So same way submandibular node में आएंगे, upper jugular में आएंगे. So lymphatics will also guide, and we need to palpate all the nodes. Now next thing after inspection palpation is we need to confirm the diagnosis, and confirm the diagnosis is gold standard is that only tissue sampling. You need to take out the tissue and under the microscope evaluate the cells. So this I think every graduate should also know. Maybe you are in a remote place, at least you will add to the diagnostic value. If you see a ulcer, how to take a biopsy, at least that knowledge you all should have, everyone should have. So when you are taking the biopsy, the important is, it's not कि ulcer दिखा तो उसके center से लेना है. You may then take a necrotic tissues. We need a growing end, like take the borders of the ulcer. उसके borders में normal tissue also we need to take. And biopsy should not be that much broad. Better it be deep, because we need to see invasion in the basement layer or in the muscle layer. So have a V-shaped biopsy going deep from the border. Like that is shown undesirable broad shape. Patient को infiltrate किया, biopsy लिया और फिर बाद में आएगा 8 days का repeat biopsy. It doesn't look good, add trauma to the patient also. So first shot में ही proper deep biopsy देना है. Send it in the formalin. Incisional biopsy usually we do for malignancy. Sometimes when the lesion is suspicious, ऐसे लग रहा है pre-malignancy है, doubtful and is very small size, we can take a margin and do excisional biopsy. FNAC may be done poorly, means spreading more and poorer prognosis. Now imaging, we need to see the extent of the involvement. The first thing usually as a dentist or we have that screening idea, कुछ भी आया केस का, the first thing we do is panoramic radiograph, and that is very good tool also. Not only tumor, cyst, impacted teeth, we see everything in one go. So this is the basics or orthopantomograph. Not ideal for malignancy, but for basic screening we should go with this. If it is a free frank malignancy, directly we can go for CT scan. CT scan, CCT बोलते हैं उसको. जैसे contrast भी डालते हैं, so that we will be seeing the vessels and the nodes involved. And this is a special technique, that is a Popchick technique, so that we can see the vestibular involvement is there or not. So best imaging is CECT, neck and PNS. We usually advance for head and neck malignancies. MRI sometime maybe for a parotid or the tongue maybe, but gold standard we can say is CECT. Ultrasound has a value because it is non-invasive. Just move the probe and you can see the neck nodes involved. This is the basic non-invasive, so we advise sometime guided FNACs also are done. X-ray is again a basic X-ray to see whether the metastasis is there in the lung or not. Nowadays we have better modalities to see metastasis, that is a PET scan. And nowadays it is getting economical also. So we can advise, so whole body scan is done not only pre-op, even post-operatively also they are done routinely to see any recurrences or metastasis, or whether the patient is disease free or not. Now ये lecture में भी question रहता है, ये exam में भी रहता है, ये TNM staging. So everyone should know TNM staging. So T, tumor, then nodes and metastasis. These three things we need to evaluate. ट्यूमर का साइज रहता है लेस देन 2 सेंटीमीटर, 2 to 4, मोर देन 4 सेंटीमीटर, सो इट फॉल्स इन T1, 2, 3. नेक नोड्स लेस देन 3 सेंटीमीटर से ज़्यादा है, कम है, दैट वे इट विल फॉल इन N1, 2, 3. और मेटास्टेसिस इज देयर और नॉट, व्हाई टू डू इट, बट इसका क्या सिग्निफिकेंस है, दैट आल्सो वी नीड टू नो. सो पेशेंट भी पूछते हैं इन विच स्टेज माय रिलेटिव और आई एम स्टैंडिंग. सो स्टेजिंग से अपने को क्या फायदा है, तो वी नो द प्रोग्नोसिस आल्सो. So statistics shows that stage 1 has much better prognosis, 85% 5-year survival rate. When we deal in malignancy तो देखते हैं 5-year survival rate कितना है. Otherwise I have taken so much efforts in this case, stage 4 में, and 5-year survival is 9 years. इतना सब कर दिया, financially भी, physically भी burden कर दिया. So then maybe I can think of palliative also. So stages will guide us in treatment and prognosis, helping the patient in showing the outcome. and make the things realistic. Now after TNM staging and detailed evaluation, the next stage is क्या करना है, management. So management usually it's a combined modality, multimodality and a team approach. Still surgery is the mainstay in head and neck region. कि डिसीज फ्री करना है तो ट्यूमर भी निकालो, नेक को भी फ्री कर दो, जितना डिसीज है पूरा निकालो, मैंडिबल, मैक्सिला, जो भी तुमको लग रहा है, मेक इट डिसीज फ्री एंड नेक आल्सो क्लीन. एंड एडिशनली रेडिएशन एंड कीमोस आर नीडेड, क्योंकि कुछ मेटास्टेसिस वी कैन नॉट सी विद द आईज, दे विल बी देयर, दे नीड टू बी टेकन केयर, अदरवाइज देयर आर चांसेस ऑफ रिकरेंस. So aim of any treatment, and same way in this treatment, is loco-regional control, anatomic. If we see the statistics, the most common recurrence is not in the neck, it is in the primary side. So primary side has to be addressed in the first go very properly, very nicely. Means holistically we can say, means proper radical we need to remove. We shouldn't be conservative. Whole compartment has to be made disease free. And at the same time we should think of कि can I preserve some functions, कि neck movements है, nerves है, can I save, but not at the cost of making disease free. First priority is making disease free. How to decide? But तो it depends again on the stage. अगर initial stage में है तो maybe a single modality, and if later stage में है 3 and 4 तो combined modality, maybe radiation and chemo has to be added. Now I will be dealing with surgical management and then followed by the chemo and radiation part. Surgery simple, excision करना है primary tumor का and neck dissection, है ना? So these are the two things we need to do. दोनों एक ही सर्जरी में करना है, ठीक है? Once the patient is on the table, we need to do both the things. पहले क्या करेंगे? This is a question for the undergraduates. I need to remove the primary and neck dissection in one surgery. But कहीं से तो शुरू करो ना, पहले primary remove कर दो, फिर neck कर लो, या उल्टा करो. So usually we start with neck dissection first, and then we go to primary. There are reasons कि spillage होगा, वो neck में जाएगा, या फिर better have a look of the larger vessels. If suppose some unwanted bleeding हुआ तो I will be able to ligate the external carotid. So we'll safeguard ourselves. So we start with neck dissection. Aim of neck dissection we already discussed कि anatomic basis है कि lymphatic drainage will be there. So remove the lymphatics with the fibrofatty tissue. There is a chain of lymphatics in the fibrofatty layer. So here we can see lymph nodes with fatty tissue. Then jugular vein, that is a large vessel, and behind that is the carotid. So taking care of the carotid, that is the most vital thing. And jugular vein, sometimes we remove it also. Then spinal axillary and sternal branch. Main thing is in neck dissection, remove all the lymphatics. So simple, but इसमें भी types रहते हैं. And spinal accessory, everything removed, that is radical. Modified में we try to preserve things. तो ये तीनों स्ट्रक्चर में से क्या बचाओगे, उसके ऊपर मॉडिफिकेशन रहेगा. I am saving spinal accessory 1, I am saving all 3, then type 3 हो जाएगा, ठीक है? Then extended and selective. So these are the types of the neck dissection. Level 1 to 4. Then we need to understand ये level 1 क्या है and level 4 क्या है. That mapping और जो lymph nodes को नेम दिया है, ये इतना बड़ा चार्ट्स है. Better we see it on the image कि कैसे simplified way में देख सकते हैं. These are the level 1, submental, submandibular. Level 2, again A और B कर दिया. Spinal accessory के नीचे है, ऊपर है, ठीक है. Then level 3 mid jugular and level 4. Level 5 को भी A and B, that is above above omohyoid and below. So these are the neck nodes which need to be addressed as per the type of neck dissection you have decided to do. Vital structures, spinal accessory रहेगा and carotid and jugular. And after removing all the nodes, the neck will look like this. Everything clean. Only the vessels and the muscles which we want to preserve are there. The anterior region is this side. That side is carotid. We can see digastric, jugular, SCM. Only good thing in onco is the surgical satisfaction. The day we do surgery, it's thrilling, adrenaline rush for the surgeon. Apart from that, when we see the post-op follow-up, the patient is never happy. That is the bad part about this specialty. Then we have seen neck dissection. What are the approaches or the incisions for the neck dissection? So these are so many approaches given. It's a surgeon preference, but there are few guidelines. Try avoiding vertical incisions because their contractions होते हैं. So mostly we go with that way. We see McPhee is the best because only horizontal incisions are there. Usually we get more assessed with Schobinger or better have a modified Schobinger. Lazy S आ जाएगा उसमें instead of giving a vertical. Then Hayes Martin also there, but try reducing that trifurcate because necrosis may occur there. So that way surgeon's preference and as per the case, different approaches are there. Then apron flap is also there. Now next is after we clear the neck, take a break and then move to the primary tumor. The basic thing in primary tumor, remove more. Don't be conservative. Wide local excision. एक simple term में अगर बोलेंगे तो it is a wide local excision. Margin around 2 centimeter. Now as per the site you are addressing, उसको नाम add हो जाएगा. Like if you are doing mandible तो mandibulectomy, maxilla तो maxillectomy, tongue है तो glossectomy, or sometimes we need to remove more things. Combination of this, the composite resections. Now थोड़ा सा as a from a dentist point of view, even though you may not be going in oral surgery, you should know कि ये और क्या क्या होता है मैंडिबुलेक्टॉमी में. तो मैंडिबुलेक्टॉमी में इट कुड बी जस्ट अ सिंपल मार्जिनल मैंडिबुलेक्टॉमी और सेगमेंटल मैंडिबुलेक्टॉमी और हेमी मैंडिबुलेक्टॉमी और टोटल मैंडिबुलेक्टॉमी. सो दीज आर द डिफरेंट टर्म्स यूज्ड एंड देयर आर क्लासिफिकेशन आल्सो कि एंटीरियर डिफेक्ट है, पोस्टीरियर डिफेक्ट है. सो कॉमन टर्म्स यूज्ड इन मैंडिबुलेक्टॉमी. सेम वे इन मैक्सिलेक्टॉमी. मैक्सिलेक्टॉमी कैन बी जस्ट एल्वियोलेक्टॉमी or involving up to the infraorbital region or orbital exenteration भी रहता है, that is vertical component, and horizontally also we can see कि कितना defect रहेगा, and there is very good classification if you are going for entrance exam तो you can see कि कौन सा है. तो maxillary defect के लिए Brown's का classification है vertical and horizontal defects. Glossectomy तो as per the extent safe margin लेना है 2 centimeter, तो the it could be a simple partial or a total glossectomy defect. Then how to remove this tumor? तो उसके लिए approach लगेगा या incision लगेगा. If they are of a smaller size, it depend on site कहाँ पे है, size कहाँ पे है, whether accessible, patient को trismus है, तो accordingly the approach is decided. Simpler, go with the simpler if it is possible per oral. सबसे simple है oral cavity में कर लो. But the lesion is large size, just to reduce the approach, don't better go on an extensive approach like मैंडिबुलेक्टॉमी. इफ आई एम एड्रेसिंग फ्लोर ऑफ माउथ तो मैंडिबुलेक्टॉमी यानी मैंडिबल को कट करके स्विंग किया एंड फ्लोर ऑफ माउथ टंग आई कैन रिमूव. These are the different approaches like lower cheek flap है and upper के लिए भी दिया है incision, that is a Weber percussion incision. Now we'll see few images of these approaches like for mandible midline split and lower apron flap taken, and the second one is a visor one, horizontal incision on the neck. In lower midline split, as we are dealing in the face, in onco we don't think much about the aesthetic, but still try to have better aesthetic. So you can modify that midline split incision. So different modifications are given. Straight दे सकते हैं, but then contraction will be more better. उसको थोड़ा घुमा लो. तो या option incision is also there, but that McGregor is also good one. तो chin का जो है, that mental is that way we can curve. And few more modification given by the Hyder. That much is not needed. McGregor I think is a good one to give aesthetic. Then approaches for maxilla, sometimes जो mandible के लिए लिया है उसी से ही maxilla approach कर सकते हैं, but specifically for maxilla we can take this incision. Can anyone name this incision? इसका नाम किसी को if you can recollect? Very nice. It's a Weber percussion incision. Again could be a MCQ question. Those happening for exam. तो Weber percussion incision for maxillectomy. निकाल दिया सब. We need to reconstruct also. Bring back patient to the normalcy as much as possible. तो basic principle रहेगा replace with the same tissue. जो निकाला है soft निकाला है तो soft, hard निकाला है तो hard, दोनों निकाला है तो same tissues you need to harvest from somewhere. So as per the defect there will be different options. Sometimes it is so superficial defect like in leukoplakia, so secondarily healing, sometimes skin graft, local flaps like nasolabial, palatal flaps, tongue flaps, regional flaps, and free flaps are nowadays very widely used because they give good light afterward, but need a special skill. So goal is to bring back normalcy, means function, aesthetic and structure as normal as possible. The first rule is replace like with like. Many times we remove the mandible and just reconstruct the PMMC. Is it easier, faster, more predictable, and the cost is also less. But that violates the first principle. Still, it is a good and commonly used option because faster हो जाता है. Then functional reconstruction, try to put implants also in the fibula which you have done. So that will be the complete reconstruction. And we will see the commonly used reconstruction option. Like this is the most commonly used PMMC. All the oncosurgeons take this on their own and sometimes called a plastic surgeon. Basic flap, chest flap है, based on a name vessel, pectoral branch of thoracoacromial artery. Develop the flap, transpose is there, maybe for the oral mucosa or both sides skin and lining of the oral mucosa we can use this. This is how the defect. And the muscle and skin from the pectoralis or chest region is used for reconstructing the oral cavity defect. This is the gold standard. If someone asks what is the gold standard in reconstruction, the mandible or even the maxilla, so this will be same. Because you are replacing bone with bone, additionally tissue coverage. Then in future you can add implant and can do complete rehabilitation with this. So this is the gold standard, anterior mandibular defect, extensive defect, fibula. This is the extra bone given by the nature. है ना, टिबिया तो है, ये एडिशनली दिया है मैंडिबल रिकंस्ट्रक्शन के लिए, एंड यू कैन गेट गुड कंट्रोल ऑफ द मैंडिबल आल्सो. रेडियल फोराम से भी ले सकते हैं. दिस इज इफ यू नीड अ थिन टिश्यू, ज़्यादा थिक नहीं चाहिए, लाइक फॉर बक्कल म्यूकोसा डिफेक्ट ओनली और फ्लोरा ऑफ माउथ टंग डिफेक्ट ओनली. सो दिस इज अ वेरी गुड ऑप्शन, रेडियल फोराम फ्लैप. Extensive things in oral cancer, extensive lesion, extensive procedures. One question comes, can we prevent these all thing extremes? Can we prevent? कर सकते क्या control? Maybe with education, awareness, और कुछ कर सकते हैं अपन as a healthcare worker, जो अपन करते भी है बहुत बार, camps लेते हैं and screening करते हैं. So we should also think on preventive aspect, because there are few people, जैसे सर ने बोला है लेबर क्लास लेते हैं, ठीक है, to stay alert वो लेते हैं, या sometime to appetite उनका hunger hide करने के लिए थोड़ा सा वो they और peer pressure से they start such deleterious habits. So they should be screened because the statistics shows that 80% of the cancers are preceded by pre-malignant conditions. So if we earliest or diagnose and prevent and treat them early, so we can prevent that progress to oral cancer. So basically lesion रहते हैं means localized area और condition complete oral cavity में रह सकता है. तो ये different नाम्स आएंगे इसमें, जैसे ल्यूकोप्लाकी आ गया, या यहाँ पे submucosal fibrosis means entire oral cavity is susceptible. You all must have seen these cases, or at least in the images you must have seen. So there are different pre-malignant, यानी इनमें pre-malignancy हो सकती है. कितने चांसेस हैं? जितने रेड स्टार ज़्यादा है उतने ज़्यादा चांसेस है. Means we can see कि proliferative verrucous leukoplakia is the highest chance, erythroplakia has the highest chance. List में आएगा lichen planus. So these are the alarming things we can explain to the patient. You all must have seen these, है ना? Answered these. So let's see how much you have seen. What is this? White patch, non-scrapable, ठीक है ना? कुछ स्लाइड्स ऐसे रहेंगे. ल्यूकोप्लाकिया, we have seen non-scrapable है, pre-malignant है, इसमें ज़्यादा potential है, ठीक है? What is this? एरिथ्रोप्लाकिया, again has a malignant potential. कुछ types रहते हैं जिसमें alarming रहते हैं, better do excision because they have high malignant potential. What is this? Only on palate.
Nicotinous palletosis.
Smoker's palate.
Smokers.
है ना? Smoker's palate रिवर्स स्मोकिंग से या नॉर्मल स्मोकिंग से होता है. What is this? Reduced mouth opening से फाइट होता है. OSMF, very common. And this is increasing the difficulty of the dental people doing treatment. अगर ये पेशेंट को caries है तो it is very difficult to do root canal also. Carious tooth है, extraction is extremely difficult. We need to violate all the principles of extraction and put our instruments to somehow remove the tooth. हाँ? और उस करने में पूरा cheek beak भी lacerate हो जाता है. So difficult to tackle these cases. Oral submucous fibrosis. Then this one.
Lichen
Very
planus.
nice, lichen planus. And this is because keeping the tobacco at the same place, pouch keratosis. This could be because of the sunlight, actinic cheilitis. And there is a concept of field cancerization. ऐसा नहीं कि एक जगह ही कैंसर होगा, फिर सेकंड साइड पे भी होता है, पेशेंट को रिकरेंस नहीं रहता है, वो सेकंड प्राइमरी रहता है, क्योंकि वो फील्ड कैंसराइजेशन के लिए ससेप्टेबल हो गई है पूरी. जैसे OSMF है, एक्सपोज तो सभी जगह हुआ ना टोबैको उसका. सो फील्ड कैंसराइजेशन इज देयर. नाउ वी नीड टू सी, जो अपन ने प्री मैलिग्नेंट देख लिया, बट कुछ नॉर्मल थिंग्स भी होती है. मेनी टाइम्स वी केम टू नो कि किसी ने नॉर्मल चीज को भी एक्सरसाइज कर दिया, हिस्टोपैथ के लिए भेज दिया. वी सी मेनी टाइम्स. तो कौन से केसेस रहते हैं वो भी अपने को पता होना चाहिए, नहीं तो कुछ भी नॉर्मल से अलग दिखा के ले बायोप्सी. तो वी शुड बी नोइंग व्हाट इज जस्ट अ डेविएशन फ्रॉम नॉर्मल, इट इज नॉर्मल. ठीक है.
Podiasis spots.
Yes, very nice. Podiasis granules. They are just a sebaceous gland. जो hair follicle के साथ में रहते हैं, यहाँ पे भी आ गए हैं. No, nothing has to be done. तो ये मुझे लगता है सबको पता होना चाहिए. नहीं तो ये alarming लगता है, ये क्या है? तो podiasis granules. ये
Linea alba.
very nice. Occlusal plane पे frictional keratosis जैसा है. Nothing has to be done. So normal also we need to know. ये क्या है? ये बहुत बार मैंने सुना है. इसे वो दिख रहा है वहाँ पे second molar के वहाँ निकालू क्या पैपेला दिख रहा है. क्या है वो? Very nice. Opening of parotid gland, that is a Stenson's duct है. नहीं निकालना है उसको, पूरा ही ब्लॉक हो जाएगा. And this one is also sometime alarming. कुछ patients में ऐसे आँख और बोलते हैं तो एकदम से दिखता है यहाँ पे है, बोले बायोप्सी लेता है. This is circumhalid papilla. If you examine carefully, base of the tongue, we can see this. This one is common. Papilla है, रुके है. Everyone knows this क्योंकि टेंशन बनाते हैं तो वो आती है. This one, can anyone tell? Sometimes everything could be normal. It is just a normal. So it's good thing it is normal. So in conclusion, it's an extensive topic and it's a team approach is needed in tackling such cases. Thank you for this opportunity.